She is an addiction physician based out of Hamilton, Ontario, and she's been working in addiction medicine for quite some time. She was one of the first sources to speak out about safer supply to me, who was willing to go on record. She had a bravery and to her, and also a strong sense of principle. And recently, we actually spoke with her about Ontario, and she explained why safer supply is running amok in Ontario, and how actually our province has led to, is regulating it even less than in BC. So everything you saw just now in BC, it's actually even worse here. So Lori, could you just introduce yourself and give us a better sense of your background before we go into all of this?
Sure. Hi everybody, I'm Lori Regenstreif.
A bit closer.
I was a family physician working in Hamilton. I've been there about 20 years.
Oh, can you guys still hear?
Can you guys hear me okay?
Oh, okay. Can you see?
Okay, how's that? Okay.
Okay, so we'll just pass it back and forth.
Working in Hamilton. I work in Hamilton. I've been doing addiction medicine about 13 years, I think. I did some of my addiction medicine training in Australia and some of it in on the job in Hamilton and around Canada. And I guess as I started to do more and more addiction medicine, I guess I got more interested in the population level issues that were starting to kind of speak out. And a lot happened between about 2016 and now, in particular between 2016 and 2023, I think, but even now. And so I've written about it a little bit, and Adam's given me and a couple of my colleagues quite a bit of courage to say more about, in particular, the way that our initially federal government and now just the system is sort of running on its own, running free, is managing opioids in Ontario. And that's just where I'll start.
Okay, so Lori, when did you first hear about safer supply, and what impact did you observe in your community and in your patients specifically?
Well, I first heard about safe supply. I mean, initially, safer supply or safe supply meant other things. It didn't mean giving people bottles of pills of very potent opioids. Safer supply, in my mind, meant giving people, so I went to, in 2017, we had our Canadian Society of Addiction Medicine meeting in Vancouver, and I went on a tour of a couple of the, what I consider to be safer supply programs, which were safe injection sites, where they would prepare and give people an opioid solution to inject. And that's what I thought safer supply was, or safe supply. And to me, that's a harm reduction strategy. It's a way of engaging people. It's a way of saying, you know what? I see you have a problem. I see where you're at right now. We're gonna do this, but then just actually the way they did it initially in Sydney, I've seen their program in Sydney, Australia. After you've finished injecting and you've chilled down a little bit and you're feeling okay, you're gonna go down the hall and talk to the nurse who looks after people with hepatitis C, and then you're gonna go talk to the counselor. There's a whole process of what we call wraparound services that are provided to people to help them engage. So there's incentivization of recovery. So that's what the harm reduction / safer supply philosophy meant to me in the beginning. But in 2018, a couple of my colleagues in Hamilton, we were sitting around in a pub, and one of them said, oh, we're gonna try starting that, the safer supply prescribing. And they said that, you know, is being done in London. And they said, oh, we've heard that she's had some really good data about, you know, her program in London. And I said to them, you guys, I don't think you should do that. I think we should wait. I don't want to be part of it, but I did more than that. I was like, I don't think you should do that yet. Give it a year or two. Like, have a closer look at her data, because it's not very impressive. She presented it in Halifax in late 2017. That's the following year's CSAM meeting, and I was still not impressed. But nevertheless, a lot of the physicians that I was working with, most of whom I trained in my community, were very excited about this, because it was, I don't know, pushing the edge of the envelope. It was, you know, avant-garde. It was trendy somehow. It was very sexy to be prescribing these pills to people. And it was kind of also very disappointing in my mind.
And so as Safer Supply became more popular in Ontario, how did that impact your community and your patients?
Well, I think it's really important that initially this was very much a little, even like it was a fringy thing, and we were all assuming it was only going to be for a couple of the really severe patients that we had who were in and out of hospital because they were getting infections in their heart, they were overdosing frequently. We were like, this is some way to bring them more into treatment. And actually the whole time I never thought of it as take home. I always thought, well, they'll give them supervised something version of this. And that's not what was happening. So I think, but what also happened was COVID happened. And so a lot of people, whatever the opioid was they were getting, whether it was a methadone treatment program or an opioid for chronic pain syndrome, they suddenly were having difficulty getting their opioids. They were having difficulty getting the pharmacy. They might have been restricted from the pharmacy because they were sick or had symptoms. They couldn't go to the clinic. They couldn't sit in a waiting room with other people because they only allowed to have so many people. So there was this sudden big restriction on people being able to get opioids. And opioids, when you're dependent on them, it's sort of non-negotiable. Like as was described in the film, people just would rather die than go into withdrawal. So that was happening a lot. People were hitting the streets, cars were pulling up and giving them opioids, often fentanyl. And the Safe Supply program ramped up. And suddenly, from June 2020, where I was seeing people on video and someone was prescribing them hydromorphones and they were selling them for $15 to $20 a pill, suddenly they've dropped down to between $2 and $5 a pill, and that happened over about a year. And so, you know, it's supply and demand, right? It doesn't take much to figure out what was going on.
So, one thing I want to clarify, in case it hasn't been clear already, is that overwhelmingly Safer Supply prescriptions are not witnessed. And that's something that doctors like Lori have been pushing for, which is mandated witness consumption for any Safer Supply drugs that are prescribed. You can't just hand people bottles and bottles and bottles of hydromorphone and say, we trust you to use them as intended. So just want to mention that. Now, Lori, you work with youth who are involved in the criminal justice system, who are in some form of custody. And in our previous conversations, you have mentioned that you've heard from these youth in Ontario that they are using diverted Safer Supply, that this is not just a BC thing. Can you tell us more about that?
Sure. So I work with boys between the ages of 12 and 19 who have been placed in custody for various crimes, both open and closed custody. Those are two different settings I work in. I always take, when I do what's called an intake, I always take a history on what drugs they're using, alcohol and so on. First thing I'm doing is screening for withdrawal, because that's something that has to be looked after right away, and it's something that's often overlooked in all custodial settings where as adults as well. We've been pushing for a number of years. It's sort of been my backstory is incarcerated populations and making sure that they're properly treated for substance use. And these boys are telling me that they're buying D8s, and it's pretty routine. Their favorite is Percocets, but they're now getting, once they go to the D8s, which are like about 2 to 3 times as strong, they find that the Percocets aren't as strong anymore, and I end up treating them. Sometimes when they're released, they continue to come to me for treatment after that because they're stuck, addicted to D8s. Some of them are 15, 16 years old. I just looked after a 16-year-old who's been using fentanyl for 2 years, started with oxycodone from a grandmother, then was getting D8s, and then that wasn't strong enough anymore because your body, most people or many people, your body becomes tolerant, and whatever you're taking isn't enough anymore. You can go into withdrawal just by taking the same amount, so you need more. Eventually, whatever you're taking isn't strong enough, you need the next strongest thing, and so they move to fentanyl. And it's also very cheap, so D8s and fentanyl are competing for which is cheaper. And the other thing with kids is the three things that are most likely to engage them in a certain drug use is that they're cheap, that they're available, and that there's a perception of safety in their use. And that's the three things that get kids engaged with drugs.
One thing that stands out from our previous conversations is how these kids know how to get D8s that haven't just been diverted from the street, but directly from harm reduction workers. And you had mentioned to me that some of the kids told you that they got their Dilaudid from the harm reduction van, and they knew exactly what to say to get these drugs. Can you elaborate on that?
Yeah, it's funny, you remember more than I do, but that's right. Yeah, from the van in St. Catharines. You know, like, that's the sort of, like, if you ask the kids, like, where did you get them? So it's not always from other patients. They've gone themselves to whatever is the place where you would go to get these prescriptions. They say, well, I've overdosed 3 times on fentanyl in the last 6 months. They know that if you say you've overdosed on fentanyl, that this is a, you know, that they're immediately going to say, oh, you need your life saved, so we're going to give you these magic beans that are going to save your life. And so there's almost like a reaction, which is to just give them fentanyl, sorry, not fentanyl, PC, it was fentanyl for a while, but hydromorphone tablets.
So recently, there's been some reporting on how corrupt pharmacies profit off safer supply, and how there's a strong incentive for them to provide safer supply instead of traditional opioid medications like methadone and Suboxone. Can you explain this for us and explain why it's a problem in Ontario?
Okay, this is really huge. And it's back of the napkin math. So we've had a system that's been incentivized for about 20 or 25 years. That there was a period of time in the 90s where we couldn't get enough, especially with AIDS. We wanted to get people, and I say we, I mean the population of physicians, the medical system, not me, but people who use drugs, who were injecting drugs, were transmitting AIDS, HIV virus. And in order to reduce that, we wanted to get them onto oral opioid replacement, which is methadone. That's what we had. And to get more people on methadone, we needed more doctors to prescribe it. And methadone is a very tricky drug to prescribe. You can't just go to any doctor or whoever and get it. It has to be done properly, or you can kill people. And it's very toxic. It has a special special metabolic property. And we have metabolic properties that interact with methadone. So in order to get more doctors to prescribe methadone around the late 90s, I guess it was OHIP, it was, you know, the government or the OMA or whoever was advocating for it at the time, pushed for better pay for doctors to prescribe methadone. And what then ended up happening was there was all these new fee codes, and some physicians, very enterprising, and pharmacies, very quickly figured out ways to mechanize this and really turn a quick buck very quickly, seeing a lot of people, you know, up to 20 in an hour, let's say. People were seeing, and still are, 80 to 100 people a day. Sometimes now they're using television screens so you can see multiple people in 5 minutes. So this has been going on where, on one hand, it was well meant that we needed to incentivize to get more doctors to prescribe to people who were injecting drugs, because it wasn't something that was really desirable to a lot of doctors. And what ended up happening was that methadone clinics became these chains. You may have heard of some of them. And these chains were, they take overhead from the doctors see high volumes, they make quite a bit of money, but so do the pharmacies that often own or co-own these clinics. And the clinics became chains. There's, I don't know, half a dozen really big ones in Ontario right now. So they found a way, and not only that, but the pharmacies loved it if the patients were on other things as well, so sleeping pills or whatever. The profit is in the fact that usually if people aren't stable, they have to come to the pharmacy every day. The pharmacy can bill ODB, Ontario Drug Benefits Program, every day for each drug. So let's say someone's on methadone, they may be on an antidepressant, they may be on something to help them sleep, they're on 3 pills. The physician writes that the patient has to come every day to get those pills and their methadone. the dose is observed, they get extra, pharmacy gets extra for an observed dose. So you can see how, this is adding up. Fast forward, it's 2022, I think, or 2023 when this started. You've got a couple of safe supply programs in each of the cities handing out hydromorphone tablets, and patients coming to their methadone clinics with hydromorphone in their samples and saying, well, but I can get that from them. How come I have to come here every day when I can just go there and get a bottle and leave? And so at some point, the methadone clinics decided they were gonna start prescribing the pills. And so people are on, and something else called slow release oral morphine, or Cadian, which is an observed dose. So I don't know if this is, I'm open for questions when I finish this, but most of the methadone clinics now can prescribe methadone, Cadian, both as observed dosing every day, so that's a ding ding, and then hand out the hydromorphone pills as a third ding, plus the other two. So as you can see, like the business model is rapidly expanding. And so we now have very large, very populous clinics prescribing hydromorphone tablets to methadone patients, whether or not they're using fentanyl, whether or not they're at risk of overdose. And frankly, people who are on a stable therapeutic dose of methadone are way less likely, they're at lower risk of overdose from fentanyl anyway, and that's a whole other.
Well, so one other way to think about this is that pharmacies, they charge dispensing fees to the provincial government for every drug that they dispense. And if you have someone who is recovering from addiction and they're stable, and they're only coming in every once in a while to take home doses for a period of time, you're not really making a lot of money there. But if you have someone who is unstable on safer supply and they're coming in every single day to pick up their safe supply prescriptions, plus all the other stuff, you can easily make a huge amount of money. So from the doctors I've spoken to, they say that a single pharmacy can make about $1 million in dispensing fees with just about 100 safer supply patients. And so there are perverses.
1.6 per year.
$1.6 million per year, yeah. And so the incentives are really perverse because the people who are struggling with addiction, they don't want to go onto methadone, they don't want to stabilize because they see that it's a lot easier to get hydromorphone pills. And for many of these clinics, many of these pharmacies, that suits them well too because they make money off of it. So it's a perverse system, which got even worse recently in Ontario with the rise of teleprescribing. Now, before I ask Lori to explain this, I just want to give a small piece of clarification here. So the federal government defunded its safer supply programs. So what this means is that Health Canada was essentially investing dozens, like tens of millions of dollars into incentivizing doctors to provide safer supply. So that's been cut. But you can still prescribe safer supply at the provincial level, much in the same way how you would prescribe any drug off-label. So in order for you to stop that, you need provincial reform. Alberta has banned the prescribing of safer supply. BC has mandated witness dosing, sort of. There's a lot of loopholes. But in Ontario, that isn't the case. And so given this lack of regulation, now we see teleprescribing, which Lori is going to explain right now.
Well, I can't say I've ever done it, but I had a colleague who I trained, who when she trained with one of the physicians who's part of one of these chains, and she said he'd have a set of headphones and there would be, I don't know whether it was one screen with 6 windows or whether it was 6 screens, but he'd literally have a person on the other end, a patient who'd be brought in by someone in an office. They'd given a urine sample. He saw them. They could be showing up in a pharmacy anywhere in the province. So the doctor might be in Toronto and they might be jetting into Hamilton, like as if we have a shortage of doctors in Hamilton. So he'd have these 6 screens and then he'd see a patient and then out they'd go and the next one and the next one and the next one. So basically, oh, okay, you're good, do another prescription. It's all very automated. So you can see a lot of people and it's all fee for service and it's volume. So I just wanted the 1.6 million. So I think it was 100 people in 1 year. The pharmacy, just with the 3 drugs, it was like $1.6 million or something, but it came out to like $40,000 if those people were on once a month treatment with something that I prescribe, which is a buprenorphine, a different product than methadone that is safer and doesn't need to be observed as closely.
And to build upon the teleprescribing problem, so as of now in Ontario, you have chains of methadone clinics that will open up video booths in pharmacies that they've partnered with. And then, someone, a drug addict, will come in, there are safer supply patients, and they will go to the booth and they'll speak to a doctor remotely for about 3 minutes or so, get their scripts, turn around, get it filled by the pharmacy, and then sell their drugs immediately outside the pharmacy a few minutes later. And if you're a doctor who's prescribing this way and you see your patients for 3 minutes via telescreen, it's really easy money. You don't have to pay for any overhead. And the one good thing that one could say about safer supply is that it kind of bribes addicts into engaging with the healthcare system when done right. But in this system, incentivizes. But in this case, there's no meaningful engagement with any healthcare provider. You can't treat someone's addiction over the course of 2 minutes on a video screen. Now, some people do say that safer supply is evidence-based. I disagree, but I'm just some guy. You are the doctor. What would you say?
Well, the evidence is basically qualitative customer satisfaction surveys, at least 25 or 30 of them by now. The other thing is, and I credit my...
Can you explain what that means?
Yes, qualitative. So you are funded by the federal government, like Health Canada, a program called SUAP. You got your money to do your safe supply prescribing and to provide what's called wraparound services, so counseling, someone to help you find housing, maybe some way to get food, like addressing a number of your basic needs. So all of that was provided under the funding that also included the prescribing of the tablets. And let's see, late in the day, where was I? Sorry.
Oh, the quality. What's it?
Yes,
What's the
so then
customer
if you want to assess your program, you just circulate a questionnaire, a survey to whoever's, alert enough to answer it. And then you collect the answers and you count them up and you show, people were 5 out of 5 happy with the program. That's qualitative research, and it's not what I would call objective findings or objective data. It's small numbers.
Well,
Yeah.
let me actually
Just ask the audience something here. So I'm going to describe a research methodology to you, and I'm going to ask you to put your hands up if you think that it's trustworthy. Okay, so you are running a safer supply program. You have maybe 30 patients. They're all addicted to opioids. You've given them their free opioids. You haven't observed them. You don't know what they do with it, but you just sort of trust them. And then you interview them, and you give them surveys. And you ask them, do you like the program where we give you free opioids? And they tell you yes. And then you ask them, are you selling the drugs? And they say, no, of course not. And they say, but if I was, it's because it's mutual aid. I'm compassionately sharing it with people who need it because they're sick. Now, put your hand up if you think that this is a reliable research methodology. Oh, I don't see any hands. I wonder why.
So one of the other really big flaws that's really surprised me, because I expected that the caliber of scientists that have become involved in this research, I would have expected more from them. I did a degree at the Dalla-Lana 10 years ago in public health, and some of these individuals were the professors there. And my husband is the one who came up with this metaphor, and that is that what they've done is they measure the benefit of these programs prescribing these tablets. They don't actually quantify the benefit of all the other services. So you get people housed. First of all, you're giving them a currency as well, regardless of whether they have what drug they're using. You're giving them some way to buy drugs. And you're giving them mental health supports, you're validating them, you're all sorts of things. Those are the wraparound services. So his suggestion was, well, think of it this way. If you take 100 people and they're starving, you starve them they fast for 2 weeks, and then you give them all 3 meals a day and a bag of chips with each meal. And at the end of a week, you ask them how if they think that bag of chips made them feel better. I think that's a really good way of describing, what has been done in terms of the research. They've assessed how well people are doing, whether it's that they're no longer engaged in sex work. Okay, well, that's because they have another source of money now, but no one's talking about the fact that there's all these other aspects of these programs that were being provided. Those are not being provided anymore with the new prescribing methods. It's just a prescription now for tablets. So I've always argued, well, just give them money. Like, if they're, just give them money. They can buy what they need.
Yeah, I mean, Safe Supply right now is so recklessly implemented that it would be better for society if we just gave addicts wads of cash. Like, literally. But to use another...
$40 a day.
Yeah, it's a lot. And here's another metaphor. Okay, imagine you had a government program that encouraged people to lose weight. And so you gave them a nutritionist, you gave them a personal trainer, you gave them a therapist to talk about the underlying mental trauma that caused them to overeat, and you gave them a free slice of cake a day, right? And then you do some research, and you say, well, the people who've been enrolled in this program, they lost a lot of weight. They seem really healthy. So obviously, we should give everyone a free slice of cake a day. That's the only rational implication. So, the research here is really bad, and now we have all this diversion, which is not being measured. Now, we're sort of running out of time, so let's do about 5 to 10 minutes of questions before we go to our next panel. Unfortunately, this microphone doesn't work, so anyone who wants to ask a question, raise your hand, and please shout.
We can try it.
Oh.
What about now?
Oh,
Okay, there you go.
Okay, so let's go. You first.
We'll just pass it around.
Right, well, I'm also from Hamilton, living in downtown, and I've just sort of recently begun sort of advocating in my community and paying attention to Safe Supply. For us, we have an MPP who, her life's work is an addiction, and she was newly elected, and my counselor is also very pro safe consumption, Safe Supply. How do you recommend I advocate in that manner besides running against them?
Well, I don't know the answer to that. I gave up on those ones. She trained under me, so I don't know. I really don't. I don't. I've like you said, it's a sad story, but I have sort of stepped back and said I can't beat this. This is way bigger than me now. There's a lot of power in this. It has a very strong political message and ideology that goes with it that in that particular riding has been there a long time. Like, it's all seen as, well, this is all about, the strength of the MVP, for example. Like, as if that has anything to do with it. But that's what people will do, is they'll link it that way. They'll politicize it immediately. And then you feel like you can't say anything. So I don't know, you may be better at it than I ever would be, because I think I failed.
Okay, let's go to Roy.
So I'm always interested, is there any mortality data? Like, I mean, giving out the free needles seem to reduce HIV and hepatitis B rates. Is there any data showing that these people who are getting Safe Supply live any longer or any healthier?
So this is another confounder. I'm glad you asked that. Another confounder here is a lot of the research that's pointed to and that the activists would point to, those patients are also on methadone. Okay, so the one out of BC, the RMG, risk mitigation guidance, it was called, that showed that more people who received these tablets were alive after 7 days.
7 days.
Yes, you heard me right, not months, days. I think over 50% of those patients were also on methadone. We know that methadone at a therapeutic dose is protective, that it maintains respiratory tolerance for people so that if they were to be exposed to fentanyl, they're less likely to have a respiratory arrest. So that's another part of this. But in terms of, no, it's kind of like what happened with the girls, where what you end up measuring, and you look at the toxicology reports, and there's fentanyl in the toxicology, so nobody's going to pay attention to hydromorphone. They'll just think, oh, what was mixed in, or nobody's going to see the relationship, the way that there's a stepwise, process where people have to go from the prescription opioids to the fentanyl, the same way people went from oxycodone to heroin in the 90s and the early 2000s.
Actually, can I?
I'm gonna answer this as well, because I actually wrote an entire article about the study that she referenced. So this was a study that came out in early 2024, and they looked at around 5,600 people who were in addiction care, some who received safe supply and some who didn't. And so they found that people in the study who received safe supply were about 55 to 90% less likely to die the week after. And so that raised two different flags. So the first flag is that typically when you look at the impact of an intervention, you look at long-term outcomes, right? If you were to give someone insulin, you don't just say, well, does it reduce their mortality after a week? You know, you think, well, if you do it, administer it week after week after week, what's the mortality after a year, after 5 years? So when the team of physicians I was working with looked at this, we found that the long-term data showed no statistically significant reduction in deaths. We also realized that they didn't filter it out for methadone, and there was a subgroup within the study that had not received methadone in the 30 days before they received safe supply. And so for that subgroup where methadone was fully filtered out, there was no statistically significant reduction in death, which suggests that any reduction that was there came from the methadone and not from the safe supply. When I emailed the lead author of this study about these concerns, his response was to send me some articles arguing that the concept of statistical insignificance is harmful and we should move away from it, like actually.
My gosh.
It's terrible.
Oh,
I can speak up. So I guess you're aware that the province has stopped funding the safe injection sites and has opened up the new heart hubs in Toronto. I went to an open house for the one on Bathurst Street, and they said this was with the promise of rehab. That was their primary goal. And apparently the wait list for a rehab bed is 7 years. So what is gonna happen to the people that are on drugs like the nitazenes and carfentanil? That you, as you said, they would rather die than withdraw from these drugs. What is gonna happen to them?
Well, so first of all, the heart hubs were not, I think it was a very rash, sudden, impulsive, decision, the way they did it. If you go back before that, we could have prevented some of the downhill slide of many people if we'd stepped in properly, 5 years ago, or even more than that, but we didn't. We don't need beds for everybody. Some people can go into outpatient treatment and do fine. We have to get some of this supply off the streets though, because it's very hard for them to do fine if they have a couple of months of sobriety under their belt and they're on, an opioid replacement and they're maybe even finding work. But there are so many pills and so many drugs out there that they climb up on a rooftop to help to figure out, to do some roofing, and someone hands them something to smoke that's got fentanyl in it. Like it's become so common. We have to start by, I shouldn't say we have to start by because there's really never less than 4 points to start at, but we do have to reduce what we're putting into the system. And we also, I think, there's a whole philosophy that has to change about allowing people the right, like it's their human right to have safe drugs when we're talking opioids. Like, I've had a couple of 15-year-olds in my lifetime, and I would never consider it their human right to have safe opioids. Like, that's not where I would start from. So there's a number of different ways we have to get at it. It is sad that I think we've let it get as far as it has, because we're really fueling not just the opioid market, but the stimulant market as well. People are taking these tablets, selling them for crystal meth, and they're using that. That's their drug of choice, or cocaine, crack cocaine. It's just fueling that. So getting back to the beds though, the idea that there's a wait list for beds, it's almost like kind of defeatist, because there are certainly people who can get well or get into outpatient treatment and do fine. We can restructure what inpatient or residential treatment looks like as well, but we also have to come up with a way of making the reality of our communities where people have got to be discharged to. Like wherever they go, they're still going to have to go home. And if they come home to somebody's got them on speed dial because they've got a bottle they want to sell right now, that's not going to be helpful for them. So seeing it in terms of, and we tend to do this, we think of things in terms of beds, and people talk about beds, but we have to think of it more in terms of the whole of community approach that we're going to take to help people and to give them something to get better for. You know, how much recovery capital have they lost? You know, their jobs, their relationships, their homes, all of that stuff. And I just feel like we've let a lot slide far, and the work is a lot bigger now than it could have been if we stepped in, 8-10 years ago.
So let's do one last question, and we'll move on to our next panel. There is a guy over there in the sweatshirt. Hoodie.
Picking up the mic.
This behind? Okay.
Thank you. So there seems to be sort of a recurring trend, which is that the medical community or some section of the medical community engages in, let's say, politically motivated experimental research and practices, right? So another similar issue, right, is the gender affirming care issue. So that happens, it makes its way through every sort of medical system, and then we have an Adam Zivo or a ragtag group of people who are able to basically bring attention to the issue years basically after it's kind of already manifested in some of the worst stuff has happened. And I'm very, very grateful for the people who are working on these things. But I ultimately find this frustrating. How do we get ahead of these issues? Why can't the medical community, when people are proposing these crazy experimental things, just say no? How do people on the, whether you're on the right side of the spectrum or not, you're just common sense focused, how do these people get ahead of the trends so that, we don't have to do a documentary showing us about, kids dying because we've dealt with the issue, as it's happening?
What a great question with no answer. No, I don't mean that there's no answer, but yeah, absolutely. I'm actually just reading Marty McCary's book, Blind Spots, and if anybody here has ever read Mistakes Were Made But Not By Me, that's also another really good one. I think we do have to some degree, learn from history. So, they are historically going back over the last 20, 30 years or more and saying, we really messed up. Look at this. Here's another example. We let, these organizations have too much power. For medical societies, for example, the College of Physicians and Surgeons of Ontario, I wouldn't even say it's powerful. They're actually kind of powerless. They've rendered themselves that way. They just don't want to even touch this. They don't like it. I think we have to go back and look at some of those other examples and figure out, although it's harder now, because that was before social media, even the whole peanut allergy thing, that was before social media. We managed to convince so many physicians through the AAP, the American Academy of Pediatrics, I think it's American, AAP, as opposed to the APA. And I think we have to figure out who decides who the experts are, who decides who a policy expert is, who a policy maker is. How is it that we don't have anything that's sustainable, that survives social trends? Like, how did Sweden and Finland and Norway and the UK to some degree and Denmark manage to transcend the social influences, for example, in gender medicine, and say, wait a minute, we got to go back to the science here because something doesn't smell right. Whereas somehow we've been sucked into more of the American, what can we sell more of faster approach. That's the best I can say about it.
One thing is that we should strive to have less politicized health reporting. One of the big things here with Safer Supply is that from the late 2010s to early 2020s, no one asked addiction doctors what they thought about Safe Supply. Like, if you were a Safe Supply evangelist, you got all sorts of free time on CBC and on CTV, but many doctors were not asked for their opinions, and they were afraid to speak up in certain cases because they feared the professional consequences of that. And so, for example, when I first was interviewing people, there were all these doctors, like, they had strong opinions, and they felt like most of their colleagues didn't support this, but that was not reflected at all in the media coverage. And I don't want to sound like one of those, like, angry conservatives who complain so much about the CBC, But the CBC, like after I did my article on this, on these people, on Camilla and all of her friends, that was in June of 2023. CTV did a piece on them as well. So you had 2 national newspapers do a piece. Then CBC did a piece on Camilla's family and completely omitted the safe supply thing. Completely. And then I actually ended up emailing them and writing an article about that. They interviewed Amelie. They interviewed Greg. They listened to Amelie describe how she developed an addiction to safer supply and how all of her friends were using safer supply. And the CBC journalist and their editors said, we're not gonna let Canadians know about that because we don't like that. It's a problem. But let's move on to our next panel with Callum Bagnall and Willa Haas, who are 2 individuals who were impacted by this diversion crisis because they used the drugs that were diverted. But thank you, Lori, for joining us.